morning, everyone, and welcome to this year of fellows. I still have the congrats to our graduate fellows from last year, but I want to also say congrats to the new fellows of this year. So I am a professor of family and community medicine at the University of California, San Francisco in Fresno. I have been a sleep physician for a while, for about 12, 13 years. And my area of research has been restless sleep, restless legs, and what now we call restless sleep disorder. So today we're going to be talking a little bit about a trip through restless sleep. And I just want to be sure that I'm sharing with you the presentation. Let's see. Is that the presentation that you're seeing or the one with the notes? Sally, maybe you can.
The presentation only.
That's good. All right, perfect. All right, I do not have any financial or any conflict of interest. And by the end of this presentation, we want to understand what are the causes of restless sleep in children, describe some of the diagnostic features of primary restless sleep disorder, perform scoring, understand the scoring, even if it's early on, but determine also some treatment options for children with restless sleep disorder. So let's talk about sleep and sleep quality. The National Sleep Foundation defines sleep quality as sleep that is restful and restorative. When we talk about our patients about sleep, we want to talk to our patients about whether they got a good night's sleep. And most of the time, we focus on quantity. So over the years as sleep doctors, we have been debating and getting to conclusions about what is the right amount of time that patients should sleep. There are guidelines that are published, but most recent in the past 10, 15 years, we're looking at other markers that are also helping us identify sleep that is non-restorative. The World Sleep Society has come up with this graph that says that sleep quality is defined as not just the quantity of sleep, but the depth of sleep and the actual characteristics of quality or continuity. So we have an interrelationship on the amount and the type of sleep in terms of depth, and also the microstructure of quality of sleep as we're gonna look at it. So when we have these three characteristics, not just the quality, not just the quantity, but also the quality and the depth of sleep, we have true restorative sleep. And why is this important? It's important because the combination of these three characteristics will contribute to our alertness, to factors in our cognition, to executive function, to our mood, and to our health. Sometimes as a physician, these are still terms that are not well understood by us. So I'll just briefly go into some of this because we need to understand what some of this terminology are when we talk to our patients and we see if they're really getting a good night's sleep. So alertness is kind of easy because we all use something called the Epworth Sleepiness Scale to assess whether they doze off in different activities. So we ask them, do you doze off while driving? Do you doze off while watching TV? Do you doze off while sitting and talking to someone? And when we get a score of 10 or higher, we say that that person is drowsy, is sleepy. And when we get lower scores, it is reassuring that that person has good alertness and they're not dozing off. So alertness is one of the easiest things that as a sleep physician, we understand. Cognition has to do with our abilities to learn and our abilities to take information and process it. And some of those have been established in research about, for example, memory. We have different types of memory, and sleep, particularly certain stages of sleep, help us consolidate those memories. So we do not recommend pulling an all-nighter anymore before an exam. We usually recommend to study and to get a good night's sleep, because during sleep, we're going to process those things better. So it is quite common to see patients that are having memory problems or lack to understand different things. that are your cognitive process. So your cognition, your ability to have memory of events, to learn new events, to be able to recognize things that you already know, your reading abilities, your language abilities, all of those abilities are affected by sleep, because during sleep stages, we process them, we consolidate them, we get better. Now, we also, as physicians, sometimes we don't grasp the concept of our executive functions. Executive functions are a group of functions or abilities that allow us to really function well in society. And some of them are decision making. Some of them are the ability to focus. For example, attention, it can be an executive function. Decision making, when we have, for example, if I am giving a lecture right now and I hear noises in the outside, if I get distracted by the noises and I suddenly walk out and I leave my lecture, that is an executive function, the ability to block the outside stimuli and focus on what you're doing. So when we see, for example, children with sleep disorders and problems with focusing, problems with attention, problems with decision making, sometimes when people get a bad night's sleep or chronically sleep deprived, what happens? They make the wrong decisions, they take the wrong job, they buy the wrong purchase, the wrong investments, because these executive functions are the ability that we have to make those decisions maturely. Also, to recognize in ourselves when we are not making those right decisions, and to inhibit the disturbances and to focus. So when we have bad night of sleep chronically, one of the very common complaint that we have, especially in children, but also in adults, is the inability to focus, the inability to block disturbances. Everything becomes a little bit more irritating. Mood is important to understand, and if you look at your ICSD-3 criteria for diagnosis of obstructive sleep apnea, for example, mood is part of it. So whether you feel depressed, whether you feel anxious, whether there is any type of mood disturbance, it is important to screen. And I'm just starting and taking a longer time in this slide because as sleep doctors, sometimes we do not really pay attention to question our patients about this. How are you making decisions? Or the partner, are you ability to concentrate? Use questionnaires, even refer our patients for neurocognitive function, which is quite common in children because we have that ability in the school system to get a neurocognitive battery testing, for example, if we want to assess for a dysfunction. And overall health, and we probably are just, this is the area that is more flooded with research, and the comorbid cardiovascular disease, the comorbid sugar imbalance, the hormonal imbalances, and all of those other health outcomes that we know when we have sleep deprivation, poor sleep quality, and poor sleep quantity. How do we assess sleep quality in patients? Well, we all know that polysomnography is the gold standard to rule out sleep disorders, especially sleep disorder breathing, but we have other tools. And in the slide, you can see down below, one of the simplest tools that we use is the sleep diary. We ask patients to fill in and put arrows when they went down to bed, and puts arrow up when they got up, and then put their arrows in the middle if they got up in the middle of the night. And that is just a very useful tool. I remember when I was a fellow, one of my very first days in fellowship, I thought, how are we going to really believe this? I mean, patients may not be accurate putting their sleep diaries, and you will be surprised how invested a lot of patients are. If they are in your clinic seeing you, they are going to do the sleep diaries. They want for you to assess their sleep quality, and they are going to fill it out and bring it back to you. Sleep diaries alone could be helpful, but also very often we put them in combination with actigraphy, and you have a download of an actigraph up here, and you can see the sleep patterns when it's lower activity, and the activity level is an accelerometer, and you have an estimate of the sleep, and you can also estimate sleep quality by seeing awakenings or movements. We have questionnaires. So you have examples of questionnaires that as simple and as direct say, does your child have restless sleep? Is your sleep poor quality? So we have a large battery of sleep questionnaires that will be talking about sleep quality and asking directly. However, just asking restless sleep and sleep quality sometimes could be vague, because what it is poor sleep quality for somebody or restless sleep for somebody could be different to someone else. You will know that when you see a polysomnography study, you will see what is called the macro architecture of sleep. So the macro architecture is almost like the skyline of a city. You drive, I remember when I moved to Philadelphia, I was driving from the freeway and I could see the skyline and some of the highlight buildings, and you could almost recognize cities in America by the landmark of the city. So sometimes the macro architecture of sleep is also recognizable of some sleep disorders. Narcolepsy, for example, could have REM really early at night, and some sleep disturbances could have a lot of awakening. So in the hypnogram, which is your bird's eye view of the sleep study, you will see wake N1, REM in red, N2 in green, N3 in yellow, and you will see this kind of skyline of the sleep overnight. You will see that cycles repeat overnight, and you will also be able to identify not just the sleep stage distribution, but you can also see if there's arousal, awakenings, and sleep disruption and make a comment. Very often in the sleep study reports, you see the sleep efficiency, and if it's less than 85%, you can say that it is sleep disruption. So you can say that it is poor sleep efficiency, and then it is a huge difference if there's poor sleep efficiency because someone woke up earlier compared to poor sleep efficiency because someone woke up 100 times through the night. And it's completely different than if someone had poor sleep efficiency because they had one large 2-hour awakening in the middle of the night. So having this kind of eye for detail will really help the doctor when you interpret the studies to see what kind of disorder this is. And finally, you can also see in the microarchitecture if there are some parasomnias, if there's an abnormal behavior in the PSG and things that can help us with the diagnosis. There is something else called the microarchitecture of sleep. And in the microarchitecture, you have things that are more granular that you can take from the EEG or from some of the leads. And some of this could be your spindles, and you can PubMed spindles and ADHD. You'll find a lot of publications. Similarly, K complexes and something called cyclic alternating pattern. Cyclic alternating pattern is something that one of these days is going to make us into the scoring manual. But so far, there's a lot of research and people are starting using it more. And it is a marker of sleep instability. And it is something that we see in the sleep study that just repeats cyclically through the sleep study. And it's a marker of non-consolidated sleep. It has been seen abnormally in some disorders with poor sleep quality. So it is called, we traditionally call it CAP, but it is cyclic alternating pattern. So when we talk about restless sleep, and this is a large introduction for restless sleep, we were wondering many years ago, and this is a little bit of a journey of how we describe restless sleep disorder. There was a large body of patients that would come, especially children, that would come to the clinic with their parents saying, this child is very restless, it's all over the place, it's moving a lot in bed, it's kicking a lot. So back a few years ago, the International Restless Study Group put me in charge along with Dan Piketty. You may have heard this name. He described restless leg syndrome in children. And we were in charge of a task force to identify whether restless sleep was its own condition and what were the markers of restless sleep in children. So as a first step, we did a systematic literature review. Systematic because it has an order, an established system of following parameters to do the literature review. So we, together with the task force, we looked at the literature and we found that there was about 100 papers that talk about restless sleep in children fitting our criteria. What we found out, and it was really enlightening, it was that restless sleep was not unified in the definition. Every paper had a different definition. It was just moving around the bed. It was using an 8-item questionnaire. movements less than 5 minutes between movements, EEG arousals, questionnaires just as your child lose sleep, using some questionnaires. There were some people that used actigraphy and some people that did PSG and just call it repetitive movements. So one of the fascinating things about sleep medicine is that it is still a field in there. I would say when I was just in the field, it was in its infancy. It was a young, very young field. I could say now we're a teenager. We're kind of like growing. We're in the teenage years of sleep medicine. So there is still a lot to define. There's still a lot of research to be done. So it is really exciting because we are shaping the field as we're growing with it and we're growing along. So we realized, hey, over the past 30 years, 40 years, since 1985, 84, we've been studying restless sleep disorder, restless sleep, but we haven't really defined it. We don't have a unified way of looking at it, and it's just all over the place. This is an example of some of the questionnaires. So this is the pediatric sleep questionnaire. Does your child have restless sleep? That could be a question that is really broad. Ultimately, the conclusion of the task force was, when we reviewed all these papers, was that whether they use questionnaire, PSG, actigraphy, all of these conditions have been associated with reports, parental reports of restless sleep and improvement of restless sleep when the conditions were treated. The biggest offenders, like with more than 80% of presence of restless sleep, were obstructive sleep apnea, restless leg syndrome, periodic leg movement disorder. But some of them also have pain, like medical conditions, medications, otitis media, and among them, restless sleep disorder, which had been a disorder that our team was working for the many, many years ago, about 5 to 6 years. So we identified as a group, as a pediatric expert group, that restless sleep disorder was a primary disorder and that these other disorders were secondary causes of restless sleep. So it was very important to identify the secondary causes, but also to assess whether or not the child had what it was called restless sleep disorder. So how do we assess restless sleep disorder? We found that the parents would come to us because it is very important. It's very easy in our labs to rule out obstructive sleep apnea, restless leg syndrome, but how do we know that this child has actually a disorder of restless sleep, which we call restless sleep disorder? So the parents report that the child thrashes all over the bed, moves like a helicopter, never stops moving, is not at rest, doesn't matter what hour of the night the child is moving. The common mimics of restless sleep disorder could still be any of these other disorders that we found in our literature, and really rare mimics could be tics, seizures, and other, just even weather, like really extreme weather temperatures like heat. You know, you can't sleep when it's really hot, you're moving, tossing, and turning, and that's found and really described in the literature. So the same task force, again, led by Dan and I, with some collaborators, international collaborators from various parts of the world, including representatives from Latin America that have been working on pediatric movement disorders for many, many years. We got together for over a year and we coined the diagnostic criteria for restless sleep disorder based on what it was written in the literature already, based on our research, and based on our clinical experience. What it was really interesting was that when I first published the first papers on restless sleep disorders, the reviewers, which are usually quite critical, if you have ever submitted something for publication, you will realize that reviewers are very high eye to detail, and they're very much invested in improving your paper and criticizing all of those things. When I submitted the first couple of papers on restless sleep disorders, all the pediatric community were very supportive and said it was about time. We need this. We see this all the time. So it is not something that was discovered from the day that we wrote this diagnostic criteria, but it's been something that if you talk to any of the pediatric sleep doctors, we've already been seeing it for years. We just needed to solidify it. So the diagnostic criteria for restless sleep disorder includes a complaint of restless sleep, as we said, reported by the parent or a caregiver, a restless sleep movements during the night that involve all the large parts like limbs, arms, legs. Movements have to be during sleep, or at least while the patient appears to be asleep. And we need video polysomnography to assess the diagnosis, and it has to have 5 or more movements, large muscle movements or large body movements per hour of sleep. Restless sleep has to occur chronically, so we picked a chronic marker and we said more than 3 months and more than 3 times per week, and has to have some of those things that we talked earlier about, some either cognitive or executive function or something that affects the child reported by the parent, behavioral, educational, academic, or social or occupational area of functioning. So some of those things could be mood, could be impaired attention, could be one of those. So very, very careful when examining, because sometimes people say that they're doing fine, and then we do a MOCA test or we do neurocognitive testing, and there are subtle deficits. So we need to be aware of those. And then that you do not have another disorder to explain it. And this is not a complete ban on the diagnosis, because we have found out that there could exist comorbidities, but it is just to make you aware that if someone has severe obstructive sleep apnea, they're going to be restless, so treat that and reassess after adenotonsillectomy or treatment. Some supportive features, something that is really supportive for those who end up with an index of 4.5 and you're like, it's borderline. If the movements occur through the whole night, and if the child does not have symptoms of insomnia, because you see the diagnosis has been validated on children that can actually speak, like over 6 years old, can verbalize their feelings. When we see the children between 1 year old or infants and 5 years old, we are kind of like a little bit in a predicament. Is this child going to develop restless leg syndrome? Does it have another movement disorder? So we are working together in having another algorithm for infants and for early childhood. But the more typical restless sleep disorder has to be diagnosed when the child is able to verbalize that no, there's no restless leg syndrome, that no, there's no other disturbances. This is a video. Let me see if it loads. May not load. It is on one of our publications. Sometimes it's a little slow to load. It's on one of our publications, and you'll be able to see the child just moving, constantly repositioning, changing positions, arms in different directions. That's unfortunate that when I put it in my laptop, it didn't work. This is also in another of our publications, is a table that compares with other movement disorders. So very important to rule out, but it's not really that difficult, because restless leg syndrome usually occurs at bedtime. You actually have the fidgeting, the movement, the discomfort at bedtime, and sleep delay is common, and decreased sleep efficiency is common, very easily confused with insomnia. Periodic leg movements have classic leg kicks during the night. So these are not large muscle movements and repositioning. There are a periodic leg movement index more than 5, and it's common in some comorbidities. Rhythmic movement disorder is, as its name said, you have head rocking, body rocking, head banging, head rolling. So these are repetitive movements in the same direction that are stereotypic. It's always the same. And bruxism is limited to grinding your teeth and clenching your jaw. So you see the artifact in the EEG, on the leads, on the maxillary leads, but you can actually look at the video and listen to the teeth grinding sounds. In this case, restless sleep disorder, you have large body movements during sleep that are not necessarily stereotypic, that are movements that can be repositioning. The child continues being asleep. There's no delay. There's no suspicion of insomnia. There is, but there is some sleep disruption. Both these 3 disorders have been associated with iron deficiency. So just keep an eye on this, because we'll briefly talk about iron deficiency and iron supplementation. Restless sleep disorder has movements that last through the night. The next time the parent tells you something that you don't know or is something new, pay attention, because we do have supportive literature that parents are usually good describers of sleep quality. So unlike a lot of other disorders in which maybe we tend to believe as pediatricians that a parent can have a different perspective, sleep Believe it or not, parents have a really good insight into the sleep of their children because it will affect them as well. So they are participants in the consequences of the poor sleep of their children. So we do have supportive evidence that the reports of the parents are quite accurate when we talk about sleep disorders. In this case, the parent would tell me, it doesn't matter what hour of the night I walk in the room, he or she is in a different position, in a different position in bed. And we confirmed it with research. We found that the child kept moving through the night. It didn't matter what hour of the night, they keep moving. The little movements that early is because less children were asleep by 10 p.m. The same with 6 a.m. Some of the texts were waking them up earlier than 6. So that's why there's less movement in that time. We did a prevalence study, a single center prevalence. This is referred population, so children that were referred to a sleep center, not the community, not in schools, but obviously is biased by being a referred population. But our biggest referred diagnosis is always OSA, despite the prevalence of OSA being very similar to restless leg syndrome. So pay attention to patients and always ask them about restless leg syndrome, especially those that still have awakenings at night after adenotonsillectomy and after their OSA is treated. Sometimes I see how some colleagues focus obsessively on every sign of potential soft snoring and airway flattening, and there is just no diagnosis, but you are attacking the airway completely to make it extremely perfect before you go into something else. And you may miss a child with restless legs, with PLMD, with restless sleep disorder, and with other sleep disorders. So always pay attention to these other disorders that have an equal prevalence to OSA. In this case, we found in our center, there was a 7.7% of patients with restless sleep disorder, a little bit less than RLS, but around the referrals for insomnia. So just kind of like interesting number to know and to compare. We started doing research, and I mentioned cyclic alternating pattern as a marker of sleep instability. And I quickly want to show you, this is the EEG pattern of an polysomnography study. As you know, EEGs already may know they are referential. They're not bipolar, so they are all referred to either a bone or a mastoid or an ear. So the auricle and the frontal lead, the central lead, the occipital lead. Even numbers is on the right, odd numbers are on the left. So just by looking at this, you can know where this channel is. So F4A1 means that there's a lead in the frontal area referred to the left auricle, and that's what you're looking at this signal. Central 4A1 is in the central lobe to the left, but when you see O1A2, that means that is the occipital left because it's odd number and the auricle on the right. And these are the electroencephalographic signals. You have also eye movement signals and chin, which are electromyogram. And cyclic alternating pattern, as I mentioned, is a pattern of repetitive cycles of waveforms. Some of them are wide, slow, which is called the phase A of the cycle, and some are fast and low amplitude, and that's the part B of the cycle. You will not be doing this routinely in the lab unless you're interested in research, and there are automated programs that calculate CAP rates and CAP sequences and CAP percentage and all of the CAP signals. And this, as I said, has been already established as a marker of sleep instability. We found different CAP cycles in children with RSD, restless legs, and control. And you can see here our controls in the squares, how different cycles could mark that there was different instability in patients both with restless leg syndrome and RSD. So these are tools that we used. We're not going to go in detail about them, but we use certain tools to look at how sleep was indeed different in these patients. We also use another tool that is heart rate variability. So in research, heart rate variability is a marker of the relationship between a sympathetic and a parasympathetic system because they control your heart rate. Usually when you go to sleep and you go into non-REM sleep, you have a parasympathetic predominance. So you have an even heart rate, slow respiration, lower blood pressure. Then when you go into REM sleep, you have bursts of sympathetic activity. And that's what it would be a normal PSG, a normal study. What happens is we had normal PSGs with no evidence of obstructive apnea. And for years, we were telling these children with restless sleep disorder that they had no problem, that it was all in their mind. And I remember even 11 years ago, some of my mentors say, well, all children are restless in sleep. They all move more than adults. Well, that just happened not to be true. And we had these extra tools to address and show that children with both restless leg syndrome, normal controls, and children with restless sleep disorder had different sympathetic, parasympathetic relationship and more activation and changes during sleep. What was really interesting is that we found that children with restless leg syndrome had more sympathetic activation during wakefulness right before sleep. And that is just intuitively normal, because if you are having restless leg syndrome and if you have the need to move your legs and that urge and it's getting to you and you have to get up and walk, obviously your heart rate is going to change and your sympathetic system is going to be more active. So it matches. That's the amazing part about research, is that you collect all of this data and then you look at it and it matches and is congruent with your clinical findings. Finally, we did a sleep study, a research study that we published a few years ago with some collaborators from Chile. So Dr. Pablo Brockman, if you ever hear his name or see him in some presentations, he's done a lot of research in spindles in Down syndrome, and he presents in national and international. He's actually in Chile, in the university in Chile. So we contacted him with our team in Italy, and we contacted him, and we said, hey, we want to, you work on spindles, you are the experts in spindles. Let's look at these PSGs on children with restless sleep disorder and see what we found. And amazingly, we found out that the spindle distribution was a little bit more towards the frontal lead. So we saw, you will know and you will learn, and some of you know already, that spindles are more predominant in the central lead. It's almost like a tiara, like the spindle represents the tiara. So they're in the center lobes, in the central aspects of your EEG. But in this case, the spindles were more frontal. And this is something that matched what we see in children with ADHD. And we were really puzzled. So this led to another research study in which we did executive function, neurocognitive testing in children, and voila, we found out that children with RSD had some deficiencies in attention. So all of this, as I say, is really fascinating because it puts the research and the neurophysiology at par with the clinical findings. Then we realized together that, well, we did all this research with our team and our group, but now how do we make it together clear that we need to have a scoring for these movements so we all can be looking together at the same thing? So as a community of sleep doctors, we can study restless sleep disorder and we can use the same metrics when we analyze the sleep studies. So we got together with experts in neurophysiology, movement disorders, PSG, and we decided on a scoring criteria, and the scoring matches a lot what is in your scoring manual. If you go to the frequently asked questions of the page of the scoring manual, there will be a question that says, how do I score restless sleep disorder? And they will link to this publication. Or you can find large muscle movement scoring in PubMed with my first name or Dr. Ferry's name. There is also a video in YouTube that Dr. Ferry and I created on how to score large muscle groups for labs, for people that just want to learn how to score it for the research. And we use the same signals. It follows the order of the scoring manual, so it uses the same signals. We do not need any extra electrodes. They're optional, but they've been shown actually by the Cincinnati group that they do not add anything extra when we're looking at restless sleep disorder. And you can use video polysomnography, which is how I started researching. You look at the video through the night. It's long and tedious and takes a lot of time. That's why we have the scoring criteria, and you don't have to look at the video as much. But it's interesting to see, and you can score the movements when they start and when they end, and you can measure the seconds, like in this case, 0 seconds, 7.3 seconds, movement of just the lower part of the body or the upper part, or both together, or a full repositioning going from the cubitus to supine, for example. You look at PSG, this is a typical movement, and you're going to be seeing this. They're often scored as arousal, but if you look at the video, they are moving, repositioning, changing arms, and it's not necessarily an arousal, but it is a movement, a large body movement. If you remember in your scoring manual, there is a mentioning of large muscle movement, but it is only in the setting that it may obscure the epoch to score the sleep stage, but they do not have an actual, so there's a gap in the scoring manual, they do not actually have the scoring for the large muscle movement. So here you start at the first, when 2 leads change in the artifact, and then they decrease back to the baseline, and then you score as a large muscle movement. Most PSG software will have the ability to put body movement or movement and indicate an index. So I know as a fact that places like Seattle Children's is scoring all their studies for large muscle movements, and that's really helpful, because then you can look at this database and publish large muscle movements in obstructive apnea, in all these disorders, which is a need in the literature. We don't have that data. Very, very media for research is this new diagnosis. We follow the patterns of the sleep. I'm not going to bore you with details of the scoring. As I said, there's a publication, there's a YouTube video, but we, as you can imagine, you can see we follow the same patterns and the same program that is used in your scoring manual, so it can be very user-friendly and very similar to what you're used in the scoring manual. There is, again, like the publication, the start, when you have 2 or more leads, when it doubles from the baseline, and it ends when it goes back to baseline, pretty much the movement. And you can see in the previews that this will not be marked as an apnea, as a leg movement, or any periodic movement, or anything, except there is a movement and the child continues in the same sleep stage. How do we treat this disorder? Well, we found, and this is a table from the very first publication on restless sleep disorder, we found that children with RSD had also low ferritin levels, even lower than children with RLS. This is just in our particular sample, but they were really low. And naturally, instinctually, supplementing iron was the first option. What we're postulating is that iron deficiency in the brain, depending on where and what transport method, or maybe what genetic predominance, can present as either RLS, PLMs, or RSD. So there are different areas of the brain, different nuclei involving motor activities, and depending on where the deficiency is, because we are finding out of this local iron deficiency in the brain, local brain sections, this will manifest different. This is a fascinating area as well, because there's a lot of research in infants, in newborns that are either premature or newborns with iron deficiency anemia. Premature is a high-risk population per se, because in the last 3 months of gestation, that's when most iron is absorbed and a lot of brain development occurs. But you look at some of the studies in neonatology, there are some things that improve with iron supplementation and some things that don't. And iron is important for dopamine pathways, but also other neurotransmitter pathways, for myelination, for hippocampal development, for a lot of functions. So message is check iron levels early in children to avoid some dysfunction. What we did is we started at Seattle Children's with the Seattle Children's and the director, Maida Chen, amazing team. We went together to hematology. We talked, we want to have a direct pathway of treating these children with IV iron. We developed a program back starting in 2018. The program lasted until I moved from Seattle. We treated more than 500 children with RLS, RSD, PLM, one of the most successful programs of all our careers with Maida Chen and I. I'm very proud of this program, and we can see how these children that had ferritin levels started at 16 really improved. This was the baseline data on children and the age and the severity of their symptoms, which was really severe, who started on oral iron or intravenous iron. And on follow-up, you can see how the ferritin levels improved, both from 16 to 34 with oral iron after 3 months, but significantly improved, obviously, with intravenous iron. And the improvement was amazing with intravenous, with a lot of patients resolving symptoms and a lot of them majorly improving, with moderate improvement with oral iron. And because this level still not the appropriate level, we needed to treat for 3 more months. So oral iron will improve, longer treatment, check in 3 months. If they're not responding or if they're not tolerating, consider IV iron. We've done it down to age 1. Very successful program. Ferritin levels after oral iron, like I said, they improve after 3 months, but this more modest improvement. So it goes from 16 to 30 to 34 in 3 months. So usually I recommend it for 5 months, 6 months, but you don't want a child suffering with restless legs for too long. So check ferritin at 3 months. If they are improving and they're into the 30s, from 16 into the 30s, to 40, if they were 20, if there is like this really significant 20, 30 unit improvement, then continue oral iron. If there is no improvement at all, this may be a non-responder, non-absorber of iron, consider IV iron. The preparation that we used is ferricarboxymaltose. That's most of our work because it's just the preparation that we had at Seattle Children, and it worked quite well with very few side effects, some of them involving fever. We calculated this. It was a 10% rate of side effects, and the most common side effect was just malaise, not feeling well, sleeping a lot on that day of the infusion. It has an inflammatory reaction type, so having infection, active infection, and active inflammation is pretty much a contraindication. If you have someone with a vasculitis, if you have someone with an active infection like a sinusitis, do not do the IV iron and postpone it until they are well, because iron is medium soup for growing of bacteria, and it creates an inflammatory response in the body. Some of the challenging cases, which were less than 10% and maybe 2 to 3%, were those kids that developed fever, because we were doing this during COVID, and we were like thinking that we need to test some of these children for COVID. But what we did is wait 3 days, and if the fever subsides, is most likely the infusion. And if symptoms can persist or worsen or develop something else, then we need to evaluate what else is going on, because they could exacerbate an infection or an inflammation. This is an algorithm, and I want to finish with this and leave some time for questions or comments. So from what we have discussed today, if you have a patient with restless sleep, or a parent that has a complaint with restless sleep on a child that is about between ages of 6 and 18, you have to address all those other bubbles that I show in one of the early slides, whether there is sleep disorder breathing, whether there is restless leg syndrome, whether there's periodic leg movement, some other medical condition. We had patients referred for IV iron, and they had significant eczema, and the eczema was untreated, and that's why they were restless. Or we can see it in the sleep study, scratching and moving, and that is not restless sleep disorder. So address the underlying problem if there is secondary restless sleep. If there is no other explanation, we do need a sleep study to diagnose restless sleep disorder. And in the sleep study, we need to score large muscle movements, and it has to be more than 5, the index, and it has to have a level of chronicity. If it just started during the summer, if it just started during the winter, if it just started because they have a new baby brother that is crying all night, look for these other clues. And if it is not chronic, give it a little time, watch, maybe check iron levels, and then do a sleep study and assess. Reassess again after the sleep disorder breathing has been treated. If you look in PubMed, restless sleep disorder is now in PubMed, and it has all this algorithm and all of these tips in a bullet type information. So that will be really helpful if you have access to PubMed. And if all of this is a yes, then restless sleep disorder is treated, is diagnosed, and you treat the comorbid iron deficiency. Note that I didn't include in this presentation, but there are some comorbid disorder. For example, ADHD and RSD we have found. We can also find residual symptoms in patients with treated obstructive apnea, patients with parasomnias. If you have patients with sleepwalking and suddenly they start waking up more, or the night terrors are more frequent, keep an eye that they may have comorbid restless sleep. Anything that disturbs sleep in children with parasomnia will worsen the severity and the frequency of the parasomnia. So keep an eye. We have already documentation in research from our colleagues in Turkey that they did increase worsening of parasomnias in children with restless sleep disorder. Children with seizures, epilepsy can also be more restless in sleep. So have a low threshold of screening for this at-risk population. I think we have some minutes for questions or comments, so I'll want to be available. And thank you again for the invitation. It's so lovely to see you, Iris.
Yeah, this is Iris Perez, and I would really thank Dr. Del Rosso for this exciting inaugural webinar for this academic year. And if there are any questions, the floor is it's open, but I would like to throw in the first questions, 2 questions. When are we going to see the scoring in the scoring manual? And 2, when are we expecting to see the diagnosis in the ICSD-3 or 4 book?
Thank you, Iris. So thank you, Iris. So I have to say, I fought with everything in my strength to include the large muscle movement in the scoring manual, because the latest scoring manual, which is the 3.0, is here to stay, and it's here to stay for a while. But what happened is our large muscle movement white paper came up in the middle of our committee being establishing the changes, and they felt, rightfully so, because it's a team of people, the majority non-pediatricians, but they felt that we needed to have a little bit more validation of the scoring, a little bit more publications. I really want to encourage every sleep center to maybe participate in ongoing validation. I know Dr. Ferry, who is leading this movement scoring criteria, he's still looking for sites to add to the validation protocols, and he's doing this also in adults. So I am, and I'm not disappointed. I'm part, as you know, I'm part of the scoring manual team. My name is in it, so I agree with the current scoring manual. I support it, and in all humility, I had to agree with the experts that we do need to have more data. Equally with the ICSD-3, text revision, the TR, Dan Piketty has been there, and if you see on the reviewer board, my name is in the TR book as well. However, we proposed it, and this was only a text revision, so it was an inline wording text revision. So we are hoping that for ICSD-4, which may be in 3-4 years.
Thank you. Sally, are there any questions in the chat?
Sorry, I was on mute. Before we do any more questions, I would like to do the polling questions quickly, if the people would please answer them. You will see those on your screen.
Dr. Del Rosso, do you see the question on the chat?
I do.
So after when Sally gives us the go ahead. Sally, are we okay to move ahead with the question?
We have just one more question.
One more.
One more. We're almost done. Okay, I guess we are finished. Go ahead. Let's see. We do
So
have
this
one
is-
question. I'm sorry, in the chat. Dr. Gupta wants to know, how does PLMS index of greater than 5 an hour reconcile with major body movement index of greater than 5 an hour in diagnosing RLS?
Absolutely. This is a wonderful and really good question. Our scoring of large muscle movements states that leg movements, so PLMs, which have a really specific criteria, that the criteria has not only the length of the movements, but also the periodicity of the movement. So to have periodic leg movement, they have to have a periodicity and they have to be only in the legs. So we score first the periodic leg movements as usual. And if there is a periodic leg movement more than 5, my opinion is that we cannot diagnose RSD in those patients, but they have already the first diagnosis, which would be elevated PLMs. So if I see elevated PLMs in children, the first thing that I think is, do they have restless leg syndrome? So PLMs is, we agree as a community that PLMs can be, and in most cases are, a manifestation of restless leg syndrome. So the question would be whether or not this child, regardless of age, has restless leg syndrome. So if it is a child with PLMs more than 5, and let's say is a 1 or a 2-year-old, I would, if they have a sleep component of disruption or difficulty sleeping, even if they have what we call behavioral insomnia, like they have difficulty falling asleep, we would still check iron levels and supplement if iron levels are low. So major body movements, exactly. There is no periodicity criteria, but we do have, as you mentioned, isolated leg movements. So the leg movement criteria, especially the International Restless Leg Study Group leg movement criteria, does differentiate between periodic and isolated leg movements. And they score the isolated leg movements, and you actually have an index, which we recommend 15 to be abnormal. But the isolated leg movements are also only isolated to the legs, and they're very typical leg movements with the flexion and extension of the toe and the foot, and they're not these large muscle movements where we're trying to differentiate, in which the whole leg is repositioned, change position to another place, move with the arms or move with the bodies. Where it can come really tricky is when we do see a leg kick with an arousal, and then the child repositions after that. So that's where the clinical eye and the really eye to detail. I always tell, my fellows that just graduated can tell you, I think my favorite word is eye to detail in sleep medicine. Look at the detail, which came first, what started first, what aroused and what disturbed the child. And I think overall, everybody who is here in academic sleep medicine, this is what differentiates us from the labs that are really looking at the sleep studies very quick and not looking at this details. What ferritin level would you keep in addition to improving in symptoms? So for children, we're using what the International Restless Leg Study Group recommends, which is 50, for adults 75. Clinically, and Iris, Dr. Perez, this is something that I would love to maybe put together a team, because I have found out that for some reason, and I think this is in one of my publications, but I would love to dig deeper. Children with neurodevelopmental disorders like autism spectrum, the levels of iron, even with the IV, don't go as high. They go to 60 to 70. And incidentally, I have found that the majority of the success in children are when the levels go above 100 with the IV iron. So we target 50, and at 50, children are definitely improving. Parents are definitely happy, but I am not afraid of supplementing a little bit higher in children. For adults, the IRLS for initial treatment with IV iron, they recommend 75, but for follow-up treatment in patients with recurrent infusions and severe RLS symptoms, they recommend 300. So you can still supplement with high ferritin levels in these patients, as long as all the other parameters are within safe margins.
There was a question, is there an age range to RSD? Would children younger than 6 years old fit the current criteria?
We need to establish this for children younger than 6. This is an area of research, future research, that it is needed. We, the reason that the preschoolers are so difficult is because they can't really verbalize restless legs, and they really can't verbalize other disturbances. So I think that we've been working with Dr. Oliviero Bruni, who is an expert in insomnia in youngsters. And he has this protocol of assessing sleep disruption that is based on both clinical and lab finding. And he calls it like a hypermotor insomnia as a precursor of one of these three disorders. So it may be that we're going to have to coexist with the uncertainty in this age group, but yet, since we know that iron is the solution for all of these 3 spectrum of movement disorders, I think it just makes sense to check iron levels in these children.
If there aren't any more questions, Sally, I would again thank Dr. Del Rosso. And for our next webinar will be on August 9, and the topic will be on opioid management of RLS, and it will be given by Dr. John Winkleman. Thank you so much for attending.
Thank you, everybody, and thanks for the invitation.